And thank you all for coming to what is our final Cancer Grand Rounds of calendar year 2018. And I'm really pleased today to have a visiting professor, special guest, and a friend who I've known as a colleague now for a couple of decades, I guess, at this point. Dr. Electra Paskett is the Marion Rowley Professor of Cancer Research at the Ohio State University. As she is the Director of the Division of Cancer Prevention and Control at the College of Medicine, Professor in Epidemiology in the College of Public Health, and the Associate Cancer Center Director for Population Sciences and Community Outreach and Engagement. And in that latter area, Electra really has, frankly, written the book. Her work in cancer epidemiology has been quite extensive, covering areas such as the role of energy balance in cancer prevention, methods of early detection, improving diagnostic and treatment services across populations, and even a unique and I think extremely productive interest in lymphedema and the complications associated with cancer therapy. But I think at a national and international level, and really in informing the National Cancer Institute, Electra has really set the standard of how we engage communities in terms of the broader mission of cancer centers. And so we were so pleased that Electra accepted our offer to speak and share her perspectives on this extremely important work. So Electra, thank you.
Thank you, Charlie. It's so nice to be here. I've never been to Yale before, and it's so nice of you to bring the Gale Force winds here to greet me. A little chilly. We get them usually in January in Ohio. And so let me just start by saying the reason it's the Ohio State University is to distinguish us from Ohio University, because we are the University of the State of Ohio. We're a land-grant institution. And so really do have a responsibility for the entire state of Ohio. So I know we have a mixture in the audience, faculty, fellows, residents, students, etc. And so I'm going to take you on a 16-year journey that we've had in addressing the problem of cervical cancer in Appalachia. And for those of you who are young in your career, you can sort of see how a research trajectory begins and develops. So when I moved to Ohio in January of 2002, this was the picture of cervical cancer death rates among white women in the United States. So the red areas are indicative of higher cervical cancer death rates. And Ohio is here, and you can see this area right here, which is the Appalachian area, similar with West Virginia and Kentucky, have some of the highest rates in the United States. And so I began a journey of trying to understand why. First, I'm going to tell you a little bit about Appalachia, because a lot of times when I go to speak, not many people know about Appalachia. Appalachia got its name from the Appalachian mountain range. It consists of 420 counties in 13 states, as you can see there, starting from New York, going all the way down around Mississippi. It's divided into the 5 regions that are color-coded there. And the area was defined by the Appalachian Regional Commission in 1965 in response to the region's deficits, specifically in poverty, low education, and low employment. There are about 25 million residents of the United States that live in Appalachia, or 8% of the total U.S. population. Some characteristics of Appalachia. It's mostly rural, but there are some urban areas. It's less racially diverse than the rest of the United States, as you can see there. And there are higher rates of poverty still today. There are 78 Appalachian counties that are considered by the federal government as economically distressed. And there's also lower education rates, both the high school graduation and bachelor's degree in Appalachia compared to the United States. If we turn to health in Appalachia, it's traditionally underserved in terms of the healthcare system. I'll just give you a little tidbit. I have 6 counties in the Appalachia, Ohio area that have no mammography facility. There's excess death rates in Appalachia, with cancer and heart disease being the leading cause of death, as is in the rest of the United States. However, cancer itself is the leading cause of death. And factors contributing to these health disparities, so health disparities are differences that should not exist, are the lower socioeconomic status, the lack of medical care facilities and healthcare providers, poor health behaviors, and poor communication with health providers. And we have stories on each of those, which unfortunately I won't have time to share unless you have specific questions. The poor health behaviors include tobacco, very higher rates of tobacco utilization, and obesity and lack of physical activity, mostly. So with that picture in mind, we submitted and competed successfully to become a Center for Population Health and Health Disparities. Ours was funded by the National Cancer Institute, but this was an interagency agreement with some centers being funded by Aging, some others by NIEHS. And the tagline for all of the projects that were funded was Cells to Society, Overcoming Health Disparities. And one of the ways that we in this initiative defined how you approach and address health disparities is through a multi-level model. So I want to take you through this multi-level model for just a minute, because this is A, the crux of my talk, B, a very important framework, and C, something that you can use if you are addressing health disparities. So this is a socioecologic model. It's also based on the social determinants of health. Many of you have heard of that. But it basically says that the reason we have disparate health outcomes or disparities in health outcomes is not just because of what the individual does, but it's an interplay of upstream factors like social conditions and policies, as well as downstream factors such as biologic and genetic pathways. And all of these interact to cause health disparities, and all of these could be specific to a certain population that you're working with. So my favorite example of a multi-level cause of disparities is lung cancer death rates in black men. Okay, we know they have higher rates of death from lung cancer. But is that only because they smoke? Well, yes, they might have higher smoking rates. But let's think about why they have higher smoking rates. So if you think of the biologic and genetic pathways, we know that there are genes to addiction. We know there is a biologic predisposition to liking menthol, which our tobacco companies know about and market actively menthol cigarettes to African American populations. So here you have a biologic factor here that really is making it hard to quit. And for a social relationship, everybody, let's just suppose everybody that they socialize with, their family, their friends, their coworkers, they smoke. So even if somebody tries to smoke, they get cued to smoking because of who they socialize with. And then suppose that they live in areas where there's a lot of this tobacco marketing, especially targeted with pictures of African Americans smoking menthol cigarettes. And let's also say that they work where you can get a smoke break. It's real easy to get a smoke break. Or they go to healthcare institutions where the doctors don't ask about cigarette use and advise and refer to smoking cessation. And then finally, let's say that they live in a state that grows tobacco and that the tobacco tax is really low. Okay, so put that all together. There's so much there, we can call it a perfect storm, for them to keep smoking. And, if you want to add here about lack of access to appropriate health care, etc., you have a lot of reasons that you have disparities in lung cancer death rates. Not all that are due because the person smokes. So keep this multi-level model in your mind. So as I mentioned, we were funded as the Center for Population Health and Health Disparities. And in our early work with the community, the Appalachian community, we developed this study logo, which sort of talks about the values that the people in Appalachia, which are important to the people in Appalachia. So family is extremely important. The state of Ohio, that's our state bird, the cardinal. And they recognize Ohio State as the state university, and so a lot of pride here. Also, libraries and churches, very important, and so we depicted those on our study logo. So the goal in our center was to understand why Appalachian Ohio women have high incidence and mortality rates for cervical cancer. And for the first 5 years of this initiative, I'm going to go through the projects that we did and the results that we found. So when we submitted our grant in 2002, this is what we knew about cervical cancer. So notice the flat, okay? Flat and 3 domains. And so we knew that smoking was a risk factor for cervical cancer, etiologic risk factor. We knew lack of screening, and we're starting to know that HPV infection was associated with cervical cancer. No HPV vaccine at this time, but we knew there was something with HPV infection. So these are the 3 projects that we started with. At the time we started the study, Appalachia was only 28 counties in Ohio. But what we did was divide those 28 into 4 regions. We picked every urban county, and then we randomly selected rural counties. And we went into those counties as depicted by the stars, and we found primary care clinics who performed Pap tests and asked them to participate in this study. So the first project was focusing on lack of Pap smear utilization. And we went to the clinics and we found women who needed a Pap test. And the goal was to use lay health advisors, it's abbreviated here by LHA, to improve the uptake of Pap smears compared to usual care. So the lay health advisor did 2 in-person visits to the woman, and then following up on where the woman was in thinking about getting a Pap test, mailed materials to them, and followed up with phone calls. And in the visit, the lay health advisor assessed cervical cancer risk of the woman, assessed the individual barriers to getting a Pap test, and then provided these educational materials. The usual care group received a letter from their doctor saying you need to come and get a Pap test, as well as the NCI brochure about Pap tests. And the women were in the program for about 10 months. So something interesting that I also learned from doing this study is I learned a lot about Appalachia and about the healthcare system there, which I'm going to tell you about right now. So we wrote in the grant that we were going to have our final result by medical record review. And here you can see, if we go over to these bars, it looks like these bars, intervention group, we had a higher rate of Pap tests versus those in the control. But the problem with the medical records were that we couldn't find some medical records. It's like, why can't you find the medical records? Well, some clinics were really close to the creek, and when the creek rose in the spring because of the rain, the clinic got flooded out. And I said, well, why can't you just move the clinic? Here from Miss New York City, right? Why can't you just move the clinic? No, it doesn't work that way. So the socioeconomic conditions that you saw for the county are mirrored in the clinics, okay? They don't necessarily have the economic backbone to move a clinic like that. So we weren't able to get all the medical records. And so we also looked at self-reported Pap status. So the truth is somewhere in the middle, because we know that women over-report. But we did have a statistically significant effect here with the self-reports. The second project focused on the second risk factor, which was tobacco cessation. And Mary Ellen Weaver's longtime collaborator is what I call a smokeologist. And she led this project. And it was focusing on, again, from those clinics, getting women who smoked, enrolling them in the study, and randomizing them either to usual care, which was the control arm, as you can see there, where a provider sent a letter and said, you know, you should really quit. Here's some print information on nicotine replacement therapy. Why don't you make an appointment and come discuss treatment options with me? Versus the intervention arm, where there was a cessation protocol delivered by the trained lay health advisor. And it was the same lay health advisor that we used in the first project. And all of the staff are from Appalachia. We hire all of our staff to work in the communities that we're working with from the community. So they delivered the protocol that had behavioral counseling, nicotine replacement therapy, and was given over a 10-week period. So these are the results for cotinine-validated cessation rates, and you can see we had a statistically significant effect at 3 months and 6 months, and then we had some slippage by 12 months. And so what Mary Ellen also found in this study was that smokers and their friends tended to be, if you think of your social network as a tree, the smokers and their friends tended to be off in the leaves. They had fewer friends and seemed to be off by themselves. And women who smoked more often reported that their friends smoked. And this will be important when I get to our second 5 years based on this data. And I'll tell you that this finding was also reported by the Framingham study, that they found that smokers had fewer friends in their social network and they were off also in the leaves. So the third study, we looked at predictors of abnormal cervical cytology, most importantly, of course, HPV. And this was led by Mac Ruffin from the University of Michigan. So what Mac did was we went to those clinics, and we had 18 clinics to start and went up to 20-something to enroll women in this study. And we just, when women were coming in for a PAP, we just enrolled them. And we enrolled over 3,000 women. And Mac was able to, first of all, look at the HPV prevalence by type. And if you'll notice, the dark bars are the prevalence in Ohio. And you can see for any type in high risk, and the types in the first the quadrivalent vaccine, they're higher in Appalachia, Ohio. So what we learned was, in the background of the Appalachian culture that I've been telling you a little bit about, we had high abnormal pap test risk. So for Mac's project, we found that for the women coming in for PAPs, the rate of abnormal PAPs was higher than was reported in the United States. Smoking prevalence was higher. It's over, in the high 20%, close to 32. And I will tell you that women with abnormal PAP, 68% of them reported smoking. We had high HPV rates, high poverty. Mac also found risky sexual behaviors. So we have early age at first intercourse, many sexual partners, and high rates of depression. Many of you might use the CESD to screen for depression. We had a high 20% reporting depression, and these are in young women. It's kind of scary. And one more thing that's not on here, but a high rate of binge drinking in, again, young women. And in parallel to that, we have less healthcare access, and the women reported lower trust in their healthcare provider. A lot of the women said, yeah, I don't know what that doctor's doing down there when he's doing the pelvic exam and the PAP. So there was a lot of really mistrust. So with that background and those results, we successfully competed for a second 5 years of our center when it was reissued. And so by then, we had developed the multi-level model. We had learned a lot more about disparities and about working in Appalachia. And so our model looked like this for the second round. Project 1 looked at kind of the downstream factors in the multi-level model and assessed gene-environment interaction. Project 2 focused on social networks. And I hope you remember some of the things I told you about, because they're going to be important here. The third project again, focused on the downstream factors, but really focusing on psychoneuroimmunology. And I'm going to explain that in just a minute. Again, using some of the findings that I told you about from the first 5 years. And then the last project was an intervention project and focused on patient and providers and increasing uptake of HPV vaccine. So we'll go to the first project. This is led by a molecular biologist. So the other factor in this study, in addition to the multi-level, we have transdisciplinary teams. So we're really ranging in spectrum from molecular biology all the way up to populations. And so I am not a molecular biologist, I am not a geneticist, and so I will explain this as best I can. So the overall goal of this study was to determine the role of heritable and somatically acquired genetic alterations in relation to key components of the TGF-beta receptor complex. And this complex, the variant forms are established cancer susceptibility alleles are associated with cancer development. And Dr. Weghorst did some preliminary studies in our first 5 years of funding, and he actually demonstrated there was a higher prevalence of this variant in the Appalachian population. So he was very interested in looking at it to see how it impacted cervical cancer development. So TGF-beta receptor pathway is frequently altered in human cancers, either somatic deletions, insertions, and mutations, causing deregulation of gene and protein expression, and the polymorphic variants are observed in SNPs and the TGF-beta receptor 1 6A allele, which is really what he was interested in. So he wanted to examine the association between various different genotypes and cancer status. So this was a case control study. He enrolled cervical cancer cases and some healthy controls. And in these populations, he obtained blood, a buccal swab, HPV testing in the healthy controls, and administered questionnaires very similar to what we administered in Project 3 in Care 1. And then we actually used the controls from Care 1, Project 3, that we didn't use in that analysis because we recruited over 3,000 women and we didn't need all the controls, on which we had collected blood, HPV tests, and questionnaires. And the diagram, the map here, shows you that we actually went into West Virginia. West Virginia is 100% Appalachian, and Appalachia, Kentucky, to help recruit for Project 1, mainly to get the cases. So this is where Project 1 was in this brownish color, and you can see 2 and 3 and 4 in the counties where we were. So when he looked at one SNP, he found that there was an interaction of smoking status by genotype, in that the homozygous never smokers, there was a protective effect for being the risk of being a case. And then when he looked at P53, which is active in apoptosis and cell cycle in cervical cancer, there was an interaction, again, of smoking status by genotype, in that those who were homozygous GG, never smokers, had a higher risk for being a case versus a control. So we are going to build our own multi-level model now, based on the results of these studies. So if Project 1 asked, what is the prevalence of genetic polymorphism in Appalachian women with cervical cancer versus controls, if we put in there genetic mechanisms as the bottom under the biologic genetic pathways, then we know that tobacco use, right, but can then the genetic mechanisms explain cervical cancer in non-smokers? And maybe they can, because not everybody who gets cervical cancer smokes. There's a higher rate, but what about the rest of the women? And this is assuming, 100% HPV. So we're taking away that's a necessary cause, and this is in addition to HPV, what is causing this. So let's move to Project 2. So remember I told you a little bit about the leaves and the trees and the social networks? So Mary Ellen took that, and she proposed this second project, which really focused on social networks in tobacco smokers. So I already told you about tobacco use, that it's a risk factor for cervical cancer, and the smoking prevalence in Ohio women is higher, and in Appalachian Ohio women, it's even higher, 32%. So the goal of Project 2 was to characterize social networks by smoking status, never, former, and current. So this is the person we interviewed called the ego, and the ego has alters, so basically your friends. So they basically said, who are your friends? Do your friends know each other? So you see these two know each other and these two know each other, even though they're friends of this person. And then she asked the ego, do your friends smoke? And then also determine the association between individual, interpersonal, workplace, and community characteristics, as well and these social networks. So we don't have a lot of time to go into all the details, but this was a cross-sectional survey administered by interviewers again. We hire interviewers from the community, face-to-face interview, and they were mostly done in the respondent's home. This is the age range, 18 to 95, with average mean age 52, and 20% were current smokers, 22% former smokers, 24% had a bachelor or higher education, and you can see the median household income. So these results, they're very confusing, very detailed, sorry, but the things I wanted to mention is that here, if the odds of being a former smoker were greater with age, and you were more likely to smoke if you were depressed, and social influence had an effect, as well as social participation, and also the more people who smoked in your network. So you know, we all have social networks, and you use your network for getting advice or spending time with them. So, you know, depending on this is who's in your advice network, who gives you who gives you advice. More likely to be smokers with more people in your advice network who smoked. And the same with the time index. And also neighborhood cohesion, which is how well do you see that your neighborhood helps each other? Is there a strong neighborhood in terms of helping? So a lot of factors influenced whether or not you smoked, including your social network. So again, if we go to building a model, social cohesion was important at the social and physical context, as well as your social networks and your social influences. Remember, if the more people in your social network smoked, the more likely you were to be a current smoker. And then we saw something with age and also depression. And this is what we were looking at. Tobacco was our factor here. So do we have here the perfect storm for cervical cancer? I talked to you a minute ago about the perfect storm for lung cancer. Do we have the perfect storm here for cervical cancer? Tobacco use is a carcinogen, and I showed you the genetics among non-smokers. Is that a problem? What about, though, infection with HPV? What about, we were very concerned now about the efficacy of the HPV vaccine, because we saw a lot of stress. We said, well, if the population is so stressed based on the economic conditions, will they be able to mount an immune response when given the HPV vaccine? So that, here's the prevalence of HPV, and so the big question we wanted to answer was, do they mount an immune response when given HPV? So Mac led this project. And this is the psychoneuroimmunology model that we developed and he tested. And basically it's saying that, the socioeconomic status, the lack of healthcare access, lack of social support in terms of Appalachia, loneliness, these are all negative psychosocial resources, and it really causes stress. In addition, we constructed this variable of Appalachian self-identity. Saying, do you consider yourself Appalachian? Because we wanted to see if the same thing that we see in the Hispanic community, known a lot as the Hispanic paradox, that people feel drawn to a community, get support from their culture, etc. We wanted to see if that happened in Appalachia. but only 50% of people said that they were Appalachian, even though they all resided in Appalachia. So this is really a mystery to us. And also we found that there's lack of coping strategies. And we all have coping strategies, plus or minus, when we are stressed. And actually what Mac found was there was lack of coping strategies. So how do they cope with all of this negativity? Well, first of all, they smoke and they drink. And I mentioned to you binge drinking. Because, this causes stress, which causes depressive symptoms. But this is just their way of treating depression, but it really doesn't treat depression. It adds depression. So what's the other way they cope? Risky sexual behaviors, increased number of sexual partners, and if that's done without condom use, and we have a history of prior abnormal PAP, we're going to have a lot of HPV exposure. And it's really the repeated HPV exposure that leads to infection. And if the infection doesn't go away, that's what causes cervical cancer. It's not just this, but it's the persistence. So if we have this perceived stress, the depression, all of this causing immune dysregulation, and we give them the vaccine, are they going to be able to mount an immune response? And that was our worry. That was the whole goal of doing this study and testing this. So Mac recruited young women, 26 and under, so that they could get the vaccine. And they were asked to come in for an exam, including a Pap test, and we gave them the vaccine, all three shots for free. The mean age, you can see, was about 23 years, mostly white, single, and you can see there only 39% identified as Appalachian, even though they all lived there. Only 4% had never had sexual intercourse, and the mean number of sexual partners at this age was 6.5. Age of first intercourse, 16.6 years. 26% current smokers, and then I want to again draw your attention to the binge drinking. 49% of drinkers said they had binge drinking in the last year. And perceived stress scale, we had a really nice modal distribution on the perceived stress scale, which is what we wanted to be able to test our hypothesis. And the CESD score, 28% were over 16, which is the threshold for referring for further screening for depression. Pretty high for a young population. So the big question, does stress impact the immune response to the HPV? So we looked at the impact of the perceived stress scale on HPV 18 titer change. We saw that a 10-unit increase in the perceived stress scale resulted in a 22% decrease in titer change, but this was not a clinically significant difference. And what impacted HPV 16 titer change? It was number of lifetime sexual partners with greater than 4, 60% titer change. And no other variables impacted the titers. So that led us very comfortably to be able to say that HPV vaccine will have an effect on the immune system of Appalachian women, very fortunately. So then we're adding more things to our boxes on this multi-level model because we have poverty and discrimination, social cohesion, neighborhood disadvantage, social support, age, SES, depression, and immune function. Those are the things that we were looking at. And we will have HPV vaccine protection against cervical cancer in this population. So then that brings us to the fourth project, which was an intervention to increase the uptake of HPV vaccine called the Parent Project. And the aims for this project were to develop and then evaluate a multi-level HPV vaccine intervention. And the levels that we focused on were parents of female adolescents. At this time, the vaccine was only recommended to girls. So we only worked with girls. Secondly, the healthcare providers. And thirdly, the health departments and providers office. And this was tested in 6 Ohio Appalachian counties as intervention counties and 6 usual care Ohio Appalachian counties. So working with the communities, control communities do not want to get nothing. You can't do that. So we developed a parallel intervention, same components, but the message was flu shots, and implemented that. And I will tell you, when you're out in the communities, real world working, things don't go as you planned. We initially wanted to work with the health departments. We got letters of support for the health departments. Yes, 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 we really want this. We have a long list of girls who need the vaccine. And then when we got the funding and we went and we said, okay, now we want the list so we can contact and consent, they didn't want to do that. They didn't want to give the names out. So we had to totally revamp our strategy and the design of our study so that we actually weren't able to get the parents from the same clinics that we were working at. We did random digit dialing, well, not really random digit dialing, more like mailed lists is what we use to get parents in the age range who had daughters. So it really had an impact on the study, but the clinics want implementation science. They don't want efficacy studies. They want intervention where you go and teach them and they work with their patients. They don't want this consent. Consenting really messes up the flow of their research and already of their operations. And I already told you that they're really stressed economically. The clinics are, and so when you throw us in there doing all the consenting, it just messes everything up. So anyway, we did our study and we recruited the sample we needed to. And my statistician called me and he said, "I have good news and bad news." I said, "Okay, what's the good news?" He said, "Statistically significant effect of your intervention." I said, "Well, what's the bad news?" And he said, "Very small effect." So you can see here, the proportion who got the first shot within the 3 months, it was 8% versus 3%, and by 6 months, it was 13 versus 7. So yes, we had a statistically significant effect, but the impact was really low. And if you go to the meetings that show these data, this is about what you're seeing with efficacy studies for interventions for HPV vaccine, unless you can do implementation science. When you do efficacy, this is what you see. And these are some predictors of who got the shot. So the older the parent, the more likely the girl was to get a shot, and if the mom worked full-time, the more likely the daughter was to get the shot. So again, I'm not showing you all of the predictors in the data, but what is predictive of HPV vaccine, socioeconomic status, which I'm using for employment, social influences of the parents, and then the healthcare system and the family. So I'll tell you how I put that in the box was that we asked, why didn't your daughter get vaccinated? You know what the number one reason was? The doctor said she didn't need it. The doctor said she wasn't old enough. The doctor said she didn't need it until she started her period. She's not sexually active, so she doesn't need the shot. All wrong. The daughter was in the project because she needed the shot. So there's a lot of misinformation that the providers are giving the parents and the children right now, well, at this time. Okay, so can we put all of these pieces together to create a multi-level model to explain cervical cancer disparities in Appalachia? So this is what the model now looks like. If we put all the pieces that I've been sharing with you in those little boxes together, in that based on what we found, that cervical cancer disparities in Appalachia are due to biologic reasons, which are genetic mechanisms, the immune factors and functions, and of course exposure to HPV, and then the individual risk factors, the tobacco use, age, socioeconomic status, education, depression, and lack of Pap test screening, social relationships, the social networks in terms of the smoking behavior, as well as the thing. Another story I'll tell you is that some of the moms in our focus groups will say, "Oh no, I'm not going to give my daughter that HPV vaccine because before I get home, my mother, who lives 2 houses down, will know I have given her the vaccine and will say, 'Why have you given her the green light to have sex?'" So really, social networks are extremely, extremely powerful, and social support and social influences. And then the social cohesion, neighborhood disadvantage we found, the healthcare system, the influence on why the girls hadn't got vaccinated, the family, and then poverty and discrimination, which is kind of everything that kind of sits over the whole thing. So, I couldn't do any of this. I didn't do any of this by myself. It really took a village to do this over the many years, as well as wonderful staff, both in Columbus and then out in our communities. And so I'd be happy to answer questions, or if you want to hear any stories, I can tell you more stories, but appreciate your time and interest.
Questions or comments?
Well, actually, that really was an expansive body of research to address the question. But now that, at this point, if you were to advise policymakers, here's the one thing you should do to fundamentally improve this in this population, what would you say?
Yeah, so, I've been accused of being pro-school mandate for HPV vaccine, and I am. I really think that we need to do that. And you can't just out of the blue impose a school mandate. You have to do it slowly with good education. But I think if we could mandate HPV vaccination, that would really, really help in schools. That would really, really, really help, because when you go to your fighter 11 years old, okay, you need these 2 shots for school, and you could consider getting this 3rd shot. And once you say that, then it's a no. I will tell you, we have a lot of anti-vaxxers in the rural areas, and my staff actually came across some clinics when we were trying to find clinics for this Project 4 who do no vaccines. The entire clinics do no vaccines, none. So that's what I would do, and actually I would move. We have a PO1 now pending. We'll know in February if we're going to get funded, but we got a really good score on the renewal. It's all implementation science in 4 Appalachian states, and 3 projects. 1, smoking cessation. 2, HPV vaccination. 3, Pap tests. Well, actually, I'll say cervical cancer screening. And we're not going to do it. We're not going to randomize. We're going to teach the clinics how to do it, how to be more efficient at those. And that is the second thing I would say, is that's what we have to start doing, is really moving to implementation science. One there, and then I'll come back to Beth.
Hi, thank you for your talk. Sangini Sheth, I'm an OBGYN and do a lot of cervical cancer screening work myself. I am wondering how the primary HPV test and the potential for the self-swab, how that may or may not fit into this community based on what you've kind of learned from this work?
Yep. So thank you for asking that question, because the project in our PO1 on cervical cancer screening is, and I have colleagues, Paul Ryder and Myra Katz, who actually have done pilot work on this. And so what we do is we send a letter, the clinic sends a letter, you need a Pap test, and if they don't come 2-3 months, then we mail the self-test. And they've gotten really good uptake of the self-swab in their preliminary studies. And the woman has to come back to talk to the doctor about the results. That seems to be the rate limiting step. But that's what we're testing in our PO1, and what we're going to do is add a navigator to help them come back to get the results from the doctor. So it's really, we're trying to bill it in the United States as for the recalcitrant women who won't come in, because the FDA has not approved it in the United States, even though it's approved in other countries. So Paul's done a fabulous job at looking at which test women prefer, if it matters, that they get special instructions versus the instructions that come with the kit, and how many women do it, how many return it, how many come back in, which really had some really good preliminary data to put into this PO1. So we're looking, we're real excited about seeing how this will work and how the doctors will accept this. So thank you for that question. Good question. Beth?
Great talk. Thank you so much. Picking up on this theme, are you also broadening it to vaccinating young men? And
yes.
And how open are the physicians to that
yes.
conversation?
So the PO1, the vaccine project, is for boys and girls. And actually, yes, we're focusing on 11 to 12, which is what the CDC focuses on, but we're also going up. Now remember, when we submitted the PO1, it was still only up to 26, so we were doing catch-up for the older population. And now, I haven't heard the ACIP. Has anybody heard? They haven't come out yet, right? They met the end of October, but they haven't come out yet with how we're going to implement up to age 45. But I think, if we get funded, then we will also actually increase it. Because I'll tell you, kind of the secret sauce for the PO1 is that all of the projects are going to be interrelated. And think of it as a family thing. So if the mom smokes and she needs cervical cancer screening, and by the way, she has children who need vaccine, we'll be able to intervene on all three of those behaviors. So that's how we wrote it. That's the secret sauce with our kind of PO1. It'll be a miracle if we are able to do it in 4 states and 12 or 16 clinics. But yeah, that's what we're doing.
2 questions, please. First one is the state line. Was there a difference in state policy or whatever throughout the region, in your result? And then the second one is, how does this extrapolate to other cancer in the Appalachian Mountain?
So I'm not quite understanding the first question, because we're in Kentucky and West Virginia. Is that what you were asking? The state?
Yes.
We didn't have a block big enough to be able to make look at any differences by state. And I'm not sure we will in our new study either be able to, because a lot of this is also cluster randomized trials where we, are at the county level or something, so we can't tell the difference. So we haven't really looked at it by counties.
Thank you for a terrific talk. It seems as though one of your secrets of success is your ability to successfully engage with community members. And I'm just curious about your strategies and your thoughts about sustainability. For instance, things like when you find a lay health liaison is effective at the community level, then what do you do when the study ends? And just in general, what are your thoughts about how we can
So we talked a little bit about that this morning. So we've been in Appalachia for 16 years, and when the grant goes away, we don't go away. So we write other grants, or we work with 7 community-based coalitions across the 32 Appalachian counties, and we initially help them each set up to be a 501c3 so they can get grant money, and we help them get little grants that they're interested in that are related to cancer in their community. And then when we have a grant application, they help us. So and when we find patient navigators, lay health advisors, or interviewers that are good, we try to keep them and move them on other projects. Or Mary Ellen got a T-Course project and hired some of them over there. So we try to keep people as long as we can, and we keep working with the community, and we focus on what they need. I'll give you just 2 brief examples of that. One county lost its only grocery store in the entire county for like 3 or 4 years. So they came to us, and we wrote a grant to AHEC and got some money to sponsor the AHEC person in their county, and they built a community garden and helped people learn how to grow container gardens and things like that for fruits and vegetables. So that helped a little bit. Now they just got a grocery store. Another county, the coalition came to us and said, Dr. Paskett, we have 48 women who have abnormal PAPs, and no physician in the county will take care of them because they don't have any insurance. So this was before Obamacare. And so we helped them write a little grant to the Appalachian Regional Commission, enough to buy a colposcope. The colposcope went in the health department. The health department donated the space and the nurse, and then we got a physician in town to donate time. And so they had a free clinic. And I didn't find out about this until about a year and a half ago, but The first woman that they saw in the clinic was developmentally disabled, a young woman who had been gang raped in high school, and she had a CIN2 or something, and they cured her, and they treated her, and she comes back every year for her routine PAP, at the clinic. And so, it really has made an impact in the community, just by helping them get that small grant for the colposcope, and they, the coalition does bingo and poker runs to get the money for the biopsy forceps and things like that. But it really, impacts the people who are most impacted by disparities by doing things like this. Yeah, sorry.
Yes, thanks so much for the important work you're doing. I have two quick questions. All these doctors that are giving wrong advice, where are they trained, and what could be done about that?
And of note, we found a very similar finding here in Connecticut. Dr. Linda Nicolai, who's done a lot of HPV vaccination research, found that it was the pediatricians saying, oh, it's kind of voluntary to have the vaccination. So
That's question one. Question two is, you mentioned that the tobacco tax is very low, thanks to big tobacco. Are they also targeting specifically the young women in those states?
Well, they have been for a long time. The tobacco companies have been targeting women. You've come a long way, baby campaigns. And I will say that, our College of Public Health, the interns in the summer went out and measured and counted the tobacco ads in Appalachia, in the mini marts and things like that, and compared it to Columbus. And the size of the tobacco ads and the number of tobacco ads are far greater in Appalachia than they are in Columbus. And, the tobacco companies are very smart with their advertising. So yes, they do target. Okay, doctors, what can we do for doctors? Yeah, that's a really big question. So we did a little pilot in 2 clinics in one county of the implementation science study. And so we went into a federally qualified health center and a health department. And the federally qualified health center, we did education. We gave them little tips on how to do it in 45 seconds, talk about HPV when you talk about the other vaccines. And a few other things that are in our program, which we call I Vaccinate. And we had a significant increase in vaccination rates, especially in the older group. The health department is very interesting to look at the changing role of health departments, especially in the rural communities, Appalachian communities. They said, they're not coming here for vaccines anymore. Seems that, with Obamacare, they're able to get vaccines for free, at their regular places of care. But what the health department did was they went to the schools and they talked to the school nurses and put posters up. And then they did a community billboard. Billboard was really big for them, one of those electronic billboards with, our posters about vaccination. So they were able to actually do the community level outreach, whereas the clinic, really focused on the clinic and reach. And what was very impactful, based on what the one provider said, was that she would go in and tell the parent, your child needs to get the vaccine, and I vaccinated my children. And she said she cannot remember maybe one parent saying no after, she gave that strong recommendation and said, and I vaccinated my children. So I think it has to be this one-on-one, whether it's academic detailing or whatever you do at the clinic level, to really change the behaviors. Because, you probably don't know, but I'm a 3-time cancer survivor. And, I would do anything so that people don't have to hear the word, you have cancer. And I was talking to a family practice physician, and, I said, we need to increase HPV vaccine uptake. We can show you. And he's like, I don't have time to talk to my patients about HPV vaccine. You know how much that hurt? That here, you have the power as a physician to actually prevent up to 6 types of cancers in your patients, and you don't have time? I was like fuming in order to say that. But that's sort of what we hear. That's exactly what we hear. And that's why I said the mandates. Unless, we change healthcare, if you're going to, have your patient population, your salary or something is based on the percent of your patient population that are within guidelines for all of the preventive care strategies. Whether it's what percent are within guidelines for cholesterol management, hypertension, all the vaccines up to date, and then you can add your screening tests. And that's actually how some of the federally qualified health centers are. So, we just got funded on an implementation science project from the Biden Moonshot for colon cancer screening, and I'm talking to these federally qualified health centers in our state who are going to work with us in Appalachia. And, I talked to one yesterday, and they're like, yeah, we want your help. Because, that's one of their metrics, is what percent of their population, 50 to 74, is up to date with colon screening. They want our help. So do we have to get like that in our healthcare systems to say, you have to be at 80% for all your teen vaccines? It is one of the HEDIS measures now. Do you all know that it's one of the HEDIS measures, and it's calculated on your entire patient population, boys and girls together, and it is all 3 shots. So if you're at 32% for boys incomplete on HPV vaccine, but you're 90% for Tdap and meningococcal, guess what your rate is? 32%. Yes. But I don't know, what's the stick with HEDIS? What's the stick? I ask people and they don't tell me. I've asked lots of people and nobody tells me. How can we use that? Because that would be another thing. If we can't mandate, then it's HEDIS.
There are these shared saving models.
Yes.
Where they work with the insurance companies and people are incentivized to hit those metrics. I know in adult medicine they do that, and my guess is in primary care as well. Just following the pathways and people get
it'd be
paid.
nice. Because I asked, our insurer, and they're like, oh yeah, we believe that, but so anyway.
Well, thank you, Electra. Thank you so much.
Thank you for your attention
all
and
right,
inviting
thank you,
me.
everyone.